I will just do a welcome and say thanks for those who are joining. And um, I know many of you have recently probably heard about uh, your case rate and may have some questions about it. And so we definitely are looking forward to this opportunity to engage and just talk about any questions that have arisen or about the maternity bundle in general. Just of note for this, hoping to record so we can provide information to other providers who have questions about this, and we'll post this to our website. And just make sure you're muting yourself. And if you can use, really, we'll be not using the chat or monitoring that for this time. So if you have questions, we'll ask you kind of verbalize them outside, or use the Q&A feature. So you'll see that there's a chat function, but there's also a Q&A. So chat for technical, Q&A or verbal comments for any other questions. So I appreciate it. And just to say, we're very excited about getting closer to launch. I'm sure many of you have a lot of questions that either are standing or you may just be recognizing that DSS is getting ready to launch this program. And so we welcome anyone here who has any questions in any capacity. We're very open to engaging, and we have been having ongoing provider forums, and we'll continue to schedule those. As of now, we are planning on launching in this program as of September 1 of this year, and are gearing up to do so. So with that, I don't think my co-lead, and sorry, I think I may have forgotten to introduce myself at the top. Apologies if I did, but I've been co-leading this. Brad Richards, Chief Medical Officer, Medical Director here at Department of Social Services, and working on with Fatmata Williams, who I think was running a little late to this meeting today, but we've been co-leading it and working very closely with the large DSS team and other rest of the team, who many of are represented here, who have a great expertise in how we've constructed this, and we should be able to answer any questions that arise. So with that, I will pass it back to Tiffany to move us forward.
Great. Thank you, Brad. We received a couple of questions related to the case rates, so we're going to go over those questions first. I will acknowledge we received questions from the Yale practice this morning, so we weren't able to include those in this document, but we will make sure to provide answers to those at a later time. And Charles, I'll pass it over to you.
Sure. Thanks for that, Tiffany. Good morning, good afternoon for most of you. Good morning for me and Grace, my actuary on the line from Mercer. We did receive these great questions, and we've compiled them in a Q&A document that's probably better considered as a live document, one that will update from time to time, add questions, perhaps modify questions as things change, if they evolve before the actual case rate gets derived, which we will be starting in June with a more recent set of data. So just a bit of background there. The case rate that you have in front of you is draft, and for most purposes illustrative, because the period of time in which the claims were captured is a time period that is not as recent as we would like it to be. So in June, we will start recreating the case rates with the most recent claims data set. That'll get us further away from events like the pandemic and others, which should continue to stabilize the claims environment to get us a better rate projecting forward. And so as opposed to just reading the questions and the answers, I'll probably just take the topic and say a little bit to it, and then pause there, and we can just move through them that way. If anybody needs a little bit more clarification, just feel free to come off mute. I don't know, Tiffany, maybe you're monitoring the Q&A. Okay, great. Then yeah, you could submit it there, and Tiffany can just pause me. So let's just dive in. If there are no questions preceding that, we can just go to number 1. Okay. So this question relates to the MFM services that happen during kind of co-management of a pregnancy. Where the MFM is part of the TIN, they will be included in the case rate. Where they are not, they've been excluded from the case rate, but included in the overall episode cost. That'll happen at the time of reconciliation.
And Charles, just for maybe those who haven't been following, there's just to add that that total cost component is at the end of the episode period, and so costs will be added up, including the case rate. And so just to say, like, there's a case rate that gets paid, can get paid starting the second trimester that goes up to 9 payments, including 90 days postpartum. And then there's an overarching reconciliation that's done to help with that's up against a target price, which we're not discussing as much today, but just for context for those who maybe not have followed as closely. And Charles, just adding a little extra there.
Yeah, that's absolutely right. And we'll talk more about the target price a little bit later. The case rate does inform the target price as well as the total reconciled. So where those MFM services are included in the TIN, we've contemplated those costs within the case rate payment. Next question is labs. How are those provided? Again, a similar way. If it's provided within the TIN, it's included in the case rate. And then where it is not, it is excluded from the case rate, but included in the target price and the reconciliation. The thing to note there is that when included in the case rate, we are assuming that future time periods would assume the same amount of utilization within that TIN, and that there wouldn't be any type of separation or deviation from that in the case rate that we're projecting.
And Charles, one question from the Q&A
Sure.
related to 1 and 2. Our in-house labor and delivery triage, emergency department, and endocrinology services provided within the tax ID handled similar to MFM services?
Yes, and Grace, you can keep me honest, but they all sound like they would, if submitted via professional claim within the tax ID. Yes, some tax IDs have a separate claiming system for their facility costs. If they were attached to the facility cost, they would not be included in the case rate. But that is typically separated by TIN. Grace?
Yeah, Charles, thanks. I just want to add that's all true. Also, we have been only including all the professional service claims that have been billed under a maternal care professional like a specialty type, right? So let's say if the doctor who provide the service during the ER visit has been billing under a, let's say, I don't know, nurse practitioner or other, that claim will not be included in the in the case rate. And also ongoing basis after the program go live, that claim will also not be zeroed out. It will just be paid fee for service. So another key here is you have to be billed. It has to be within the right TIN, the attributed provider TIN. It has to be a claim, like the procedure code has, or the code has to be on the zero pay code list. And also the billing provider type has to be correct, meaning it has to be an OB, a nurse practitioner for maternal care services. I don't remember the exact naming, but there has to be one of the maternal care specialty type. So that's another thing I just want to note. If it's billed under a different specialty type, it will not be included in the case rate.
Good note. Thank you. Okay, head into number 3, labs and radiologies for non-maternity diagnoses will be paid fee for service. All of the labs and radiology that's attached to the case rate build out all have the precursors that Grace talked about and getting attached. So in the instances where they don't attach to a maternity diagnosis, one of the codes that we have, or one of the diagnosis codes that we had, it would fall out to fee for service and not be zero paid. And we, in the build out of the case rate, have not contemplated any of those. Is there a definition of first trimester? Yes, and it's loosely defined in our methodology as ending at the 13th week. And where we drew that line was mostly because of our diagnosis codes identify, most of them identify the week of pregnancy or identify the second trimester. So that's where we have actually drawn that line for purposes of the case rate build out, understanding that that line, I believe, shifts a little bit in some instances, but for purposes of the case rate, we've taken it based on the claims that we're seeing, and all of the claims have an identifier. I think nearly all of them do. The vast majority of them having either a weekly designation within the term of the pregnancy or a categorization of second or third trimester. Does this cover all types of births and deliveries? All types of births and deliveries that have a professional fee component, yes, that includes the vaginal cesarean. There are instances where within a birth, an event happens that causes the case rate payment to stop. A termination of the birth, a miscarriage, abortion, a stillborn, those types of events that are listed there. And so the case rate payment is exclusive and just includes the cost of professional fees. Again, those facility fees are kept out and are typically billed separately of the professional fees. At this time, we did not include the $21 add-on payment in the numbers that you received. In the future, they will happen in conjunction, but for now, they're being held out of the numbers that you're seeing. So this question, number 8, the global reconciliation or the granularity of it. I think we're still trying to sort out exactly what the best way to do that is. Understanding how cumbersome it is to actually record a recorded event like a doula service, an instance where there isn't some other billing mechanism happening. When there is a fee-for-service claim later in the system after the schedule is developed and it's available there, that's a more distinct way of doing it, but we'll still run into the problem wherein doula services are offered under contract of the provider and essentially in-house. And so there we are looking for a means of scrubbing EMRs for the larger practices that would allow us to discern the information needed to make sure that there's no duplication or that you get appropriate credit for the particular doula service that's rendered. At this time, there isn't any mechanism or collection of information that gives us enough information to be able to pinpoint the doula service. The other methods of perhaps accounting for it are things like cost reports or separate encounter submission forms. And so we're examining that with some of the providers that are participating here, as well as trying to get something that we can vet with the larger group as a system solution for sorting that out. So number 9 deals with a member leaving the group and seeking care elsewhere. And so for the case rate payment, the case rate payment will move with the member as long as subsequent providers meet all the criteria, the triggering diagnosis, and then the claim code on the zero pay code. So it would move as much as that individual member moved, and then for months where the member has moved or received care from 2 qualifying providers. As of right now with CMS, with our federal approvers, we have socialized the idea that payment can be made to both providers during that month. And then the subsequent month, there would be the provider that proves out continuing care. If that makes sense, otherwise I can try to explain it a little bit differently. But the idea here being that the case rate continues to move with the member, as long as the member is moving to accountable providers and that meet all the criteria. If the member moves to a provider that is not someone eligible for the program, then the case rate payment would stop to the previous provider because there was a qualifying event that essentially moved the case out of their care, but not to a provider that is on the list of eligible providers. As a quick refresher, those on the list of eligible providers are those providers that have a historical amount of births above the 30 birth line. Question 10 deals with transparency and details submitted. There's a considerable amount of detail already out there. Tiffany recorded an amazing case rate explanation video. We'll have this form to continue to kind of provide transparency on how we develop the rates. We don't anticipate providing any type of models or model support that might allow you to reverse engineer the numbers or kind of prove them out. That exercise would be really cumbersome because you would have to discern the attribution process and then run the code towards that, and then get your qualifiers and your exclusions in there. So we don't know a real reasonable way of providing more detail than what we have. But if there is concern about the episode count that's included or the number itself, we are available to help talk it through. If there is something unique in the situation of the case rates for your provider group or your TIN, we are welcoming and having conversations right now. One of the more common ones we're seeing is that services split across TINs. So there may or may not have been enough of the episodes included in a particular TIN. So that's one of the ones that we're seeing now and dealing with, but any number of them could come up. We are more than welcome to discuss it. Yeah. Specific dollars on incentive payments and shared savings. So we are in the process right now of settling the target price for the reconciliation dry run. When we say dry run, what that means is that we've created the entire model and run an attributed group through the model to make sure that our numbers come out right, reasonable. It won't have any real detail about what your target price is expected because the target price is derived at the end of the performance period, looking back on your claims experience. So the specific kind of dollars at play won't be known until the end of the first performance year. Ahead of that, what we can do is give you the historical target price and historical dry run information to use as a perhaps benchmark or kind of a guiding point to give you an idea of the potential of dollars that are in play. In no way can we, until the performance year, create a scenario wherein you've created efficiencies in moving cesarean births to vaginal births and creating savings. We wouldn't be able to mock that up in any type of reliable way. So instead, what we will be giving you is your target price trended against your reconciliation price, which doesn't help you really discern what type of savings you could generate or incentive payment you could generate through intervention during the performance year. But it'll give you an idea of the volume of services that are occurring and where the costs are. During the performance year, we will be creating a cost dashboard that allows you to a better look into the costs as they're happening. It won't be 100% real time, but it will be on a short lag. So you'll be able to see the kind of trend lines of where the cost experience is heading. And hopefully that'll give you an idea of where you could put your resources and how to best target different interventions to kind of see different outcomes that would affect your incentive payment and your shared savings. I'll pause there because that doesn't sound very assuring, but that's where we're at right now. Brad, Grace, do you have anything to add there?
Just to say, I think appreciate the overview on that, Charles. I think it is helpful that we are going to be looking to make the data sharing as kind of iterative and helpful over time as we can. And so just to say that this is something that's being developed and will need continued engagement, and we will look to all of you to say, like, is the information we're sharing with you helpful? And does it make it easier for you to operate in this environment in this bundle? So just to say, we will be looking for that, and we'll need that to make it the most useful moving forward and to make it helpful for all of you to know this is how I'm performing, this is what our data looks like, that how DSS is seeing it. And so just make a plug for that.
All right, we are moving to 12, or is 11 the end?
I think 11's our end, so we have a couple other questions in the Q&A feature. First one clarifying the accountable provider term. Does the accountable provider mean a maternity provider who bills professionally under the same TIN?
Grace, maybe you can help me out there.
Sure. Yeah, Charles. Sorry. So thanks for the question. So on the starting from performance year 1, so 9/1/24, the system will start looking for trigger events, which is one of the code lists we provided on the website. So if a trigger event happens, this particular TIN will be considered as the accountable providers. Will be considered as the attributed providers. So the case rate will start right then and there, and it will continue to be made every month until another TIN bill another claim with a trigger event. So a trigger code. So that's what we're considered as attributed providers. And the accountable providers is going, I think that's a terminology a little bit confusing. Accountable provider is going to be considered as the providers who, based on their historical experience, have been attributed for at least 30 cases. So those providers will have a case rate assigned to them versus the other providers, even though they still can be the attributed provider, but they will not be accountable because even though they can trigger a case to be associated with them, however, they won't get case rate because they don't have one, because they don't have enough case count in the past. So they will be attributed provider, but they will get a fee for service payment for each individual claims that they've billed. So there's a slight difference there. Hopefully that answers the question.
Great, and I'll try to give an example just because I think it's probably, this is super technical and in the weeds a little bit, which is really important. Obviously, we need to be really clear about how this program operates, but just as an example, say I'm not an OB/GYN, I'm a general internist, but let's pretend I am for a moment, and I have in my TIN provider group, we have more than 30 births, so we're in the maternity bundle, we can be accountable. We're seeing someone, in the first trimester, we would bill the fee for service billing. In the second trimester, we bill our trigger code. We initiate a case rate. We continue to see them for a few visits, maybe maybe 2 months, and then they switch to another provider group. That's not an attributable provider. They below the 30 birth threshold. They see them in that practice. They bill, it actually will switch off the case rate to our group, and the other group who doesn't qualify to be participating in the maternity bundle above that 30 birth threshold will just bill fee for service for the remainder in that case. So that can occur with a switch. The other piece would be like someone seeing a fee for service provider that doesn't meet the 30 birth threshold, but they switch to me in reverse. Then I would initiate and it's in the second trimester, let's say it's the beginning of the second trimester, I would then initiate using the trigger codes, initiate the case rate. I would start to receive the case rate, and then I could through the postpartum period, and in the back end, because I remain the provider receiving the case rate, I can get the global attribution or accountability for the overarching bundle, and so that's where the target price and the total cost of care will come into play. Grace, Charles, anything you want to modify what I just said?
No, I don't want to modify it. I mean, we haven't been in the program developing we can still get spun around on it. So I think maybe what we need to do is just fall back on the definitions document, repost that, and we also have a visual that'll take you through that sequencing of when somebody becomes attributed, when they're not, and then who becomes the ultimately accountable provider. Because I think I started all this by saying it wrong with the accountable provider earlier in like number 3 or something like that, which I may have had it backwards. So maybe we just we kind of table that for later. I think the big question is every time a maternity provider who bills professionally under the same TIN, are they going to be is it going to be zero paid within the 10? And that answer is yes if it's already triggered, no if it hasn't. So I think that's more of the hopefully that's more clarification outside of trying to technically assign the name to the provider is when is it zero paid? When is it contemplated within the case rate? And that is if it's by a professional service by a maternity provider within the 10 after a triggering event.
And just to add to that, Charles, so the accountable providers are the ones who will get a case rate. Anyone else, whether you attribute it or not, is going to be paid fee for service. The accountable ones are the provider who has historically had 30 cases to have a large enough pool for us to develop a case rate to replace the fee for service payment. So if you receive, as a provider group, if you received a case rate letter and on the letter you see the attributed cases are larger or equal to 30, then that means you will get that couple $100 case rate when you become attributed to the case. If you don't get a letter like that, no matter you get attributed or not in year one, you will remain your fee for service payments as usual. But the benefit of being the attributed provider is at the end of the year, when we reevaluate your case counts for performance year one, if you now have more than 30 cases, you will be qualified for a case rate for year two onward. So you still want, we still want to account for the cases that each provider are taking care of, so that when you increase your clientele, in a sense, you have more cases that you've been taking care of. In the future years, you will get your case rates, because then you become accountable at that point on. Sorry, that's a long answer. Again.
Clear as mud. We'll try to put together a graphic that illustrates it,
Yep.
kind of point in time, and we'll give some examples with it, and hopefully that'll help kind of clarify how you navigate into the attributed accountable provider space and get your case rate payment, and then whose services within that case rate payment are zero paid within your 10.
Next question, how are outpatient facility fees handled when the OB-GYN or MFM practice is a hospital outpatient department?
I can start out answering that. Grace, Brad, you can help me out. So all of the hospital outpatient department services that are facility claims are outside of the case rate. And this harkens back to that other question, if it's MFM or an OB-GYN is providing the service, even if it's in the context of the hospital setting, if they bill to a professional service, that service would be contemplated in the case rate payment. It would also be zero paid if it's part of the zero pay list and is post a trigger. So where unrelated to your practice, they're all held out of the case rate payment.
Yep, Charles, I just want to add, so basically the case rate is only going to cover professional service costs. So if there is a outpatient delivery event, anything billed as an inpatient or facility claim, anything on that facility claim has nothing to do with case rate. It will be part of the target price, but it will not be part of the case rate at all. Only the professional claims that go along with this delivery event will potentially be included in the case rate. Again, that will be based on whether the professional delivery service are billed under the same TIN that who has been the attributed provider or not. If, let's say, if I'm a professional, I'm an OB and I've been taking care of this case, so I'm the attributed provider, but I happen to not be the professional, I haven't been providing the professional delivery cost, someone else is providing that service, then that claim will not be part of the case rate. But I will still get my case rate ongoing because that professional delivery cost claim is not a trigger event. So this new provider who provided the professional delivery service is not going to trigger that case to be attributed to them. So I'm still the attributed provider and I will still get my case rate until 3 months postpartum. But But since I don't have the professional delivery claims, so no claim will need to be zeroed out. I'm just going to get my case rate. And then the other provider who's been providing the professional delivery service will get their claim fee for service. So nobody is going to lose nothing.
Next question, what stops consultative MFM visits or ER visits trigger an attribution change under this logic?
I can take that. So again, we looked at the trigger code. So it really is kind of independent of whether it's MFM visits or ER visits. What really matter is on the professional claim, if there is a trigger code or not. Again, the full trigger code list is provided on the site. So if you can take a look, for instance, if you have one of those codes built on the claim alongside with a E&M code, then this new MFM or this professional provider during that ER visit can take over the case. So it really doesn't matter the visit type. What matters is that the code on there. You know, I would again, I haven't really verified, but I would imagine during an ER visit, it's probably less likely to have a sort of, a prenatal check or something, and unless it's something, I don't know, like I would imagine that in the ER visit setting, it's less likely a provider will bill a trigger event. Usually those are like the regular, OB visits, things like that. But the full code list is posted on the website.
Yeah, and I think just to add a little bit there, stops consultative MFM. To me, that says somebody that's not within our practice that's providing a co-management service or a temporary service. I think I won't bother naming them, but in those instances, like Grace said, that MFM would have to be an accountable provider, and also have to be submitting the trigger code. And if that's the case, then you both would be paid a case rate because they could take on cases. If the MFM isn't an accountable provider or is not submitting the triggering codes, then they would be left out and they would get fee for service and you retain your case rate payment.
Yep.
And both can potentially get case rates in the course of a month as well. So, which is, I think, is just important to point out. So if you have an MFM practice that's a separate TIN, those providers can say I'm, in this case, the OBGYN, and say Tiffany's the maternal fetal medicine provider in a separate TIN, and we're both potentially the MFM practice is actually above the 30 birth threshold. They're actually potentially an accountable provider for our purposes. We both are going back and foreseeing the person on a monthly basis. If we submit a trigger code every single month when I am seeing them as the OBGYN, I will get a case rate every month. It would switch. So if Tiffany does that, it also will generate a case rate. They both can be paid in that same month. So say that's September, I see the beginning of September, Tiffany sees the end of September, we both submitted a case rate, a trigger code, we both can receive case rate at the end of that month. So the goal is to make sure that we are paying providers for the services they're providing and making sure that someone's not being left out. So it's not necessarily like, oh, I saw them in the beginning of the month, Tiffany saw them last, Tiffany's the only one that gets the case rate. Both would get it as long as we're both submitting the trigger code. Now, I will just add that if Tiffany was the last one, I would need to see them the next month and submit a similar trigger event to reinstate the case rate for myself as the provider in that case. So again, knowing that in a lot of these cases, these are fairly complicated cases when you're involved, when you're co-managing, that would likely occur, but it's just important to point that out. And Charles, Grace, anything you want to add to that?
No, the only thing I'd add is that we've contemplated that in the build out of the case rate. In particular instances where a MFM has co-managed for a short duration, a couple of months, we've captured those costs and they are put into the bucket of their case rate. And then the balance of costs are put into the other co-managers' costs. So the idea in building out the case rates is we went and we performed this attribution and then this is assignment or attribution of episode logic throughout the course of the dry run period of claims that we took. And that allowed us to get segments of management for all of your episodes within that 10. And then, so there isn't a all but, it's not, there's an episode, your 10, all costs are in your case rate payment. We have actually run this attribution to narrow the experience of the management to your practice, your 10, I should say.
Tiffany, anything else you wanted to add?
No, I think that makes sense. There was a similar question asking, MFM is a consulting specialty. So if a patient has a complication such as preeclampsia and the MFM provides inpatient consultation, how would they get paid? Similar to the example but Brad provided, if the OB provides care and then recommends an inpatient consultation with the MFM and both providers bill with a trigger event, both of those providers would receive the case rate at the end of the month. In the subsequent month, the provider who provides care, if it goes back to the OB provider and they have the trigger event, they'll continue to receive the case rate. If it goes to the MFM provider and they continue to do a consultation for care, they'll receive the case rate with the trigger event.
Provided they're an accountable provider.
Yes, with that caveat.
Otherwise, it's just a consultation to an MFM that's not participating in the program and would never take your case. They would remain just fee for service.
Next question, are payments for services given in the OB office like admin of flu, COVID, or Tdap vaccines going to be included in the case rate?
I would have to go back and look at vaccines and how we handled those. Here we go. That's a good. Grace, do you happen to remember?
I don't, I would assume, sorry, not assume. I don't think the flu and COVID are on it, but for Tdap, Dr. Richards, I think you noted early on when we were clear out and refine a list, you mentioned that should be excluded, right? I think.
Yeah, and so we will triple check, but that as of now, the goal had been to exclude vaccines from the list. And I think on that same line, you'll see, Tiffany, thanks for flashing this up, IUDs, LARCs would be also excluded and paid in a fee-for-service manner as well. So you'll see on the left-hand side, the included services, and then those excluded services on the right. The goal of, again, making sure that there's access to that. And that's kind of how we decided this early on, was that we'd rather pay those fee-for-service, especially for anything that's potentially costly for providers to administer. And that has those are big win-wins across the board for a patient, provider, and the state.
Next question, is the year from dates of service 9/1/2024 till 9/1/2021 going to determine if an attributed
attributed to go accountable? I think the question there is, are you going to be determined eligible to participate or eligible to play based on the performance year? And the answer to that is no. It's going to be a preceding time period in which you will qualify as a 10 that can participate as an accountable provider. If I read that question right.
I think so, Charles. I think that's what I interpreted as well. But please feel free to, whoever asked, and feel free to either jump in or ask that question again. Just to make sure we're getting it right.
Yeah, and also for the time frame asked in the question, the 9/1/24 till August 31st, 25. For that 1 year, the case count will be used to decide who is accountable or not in the year after.
Yeah. Good point. Grace, do we know the time period in which we're gonna derive the case rate payment? I believe we talked about that, settled it, and I don't think it made it to the Q&A document, but we do know the time period in which we're gonna grab to create the list of qualified providers to participate in the program.
Yep, it will likely be, I want to confirm it's not date of service, it's date of delivery. So we ensure all the cases are all the case rate and everything preset are going to be calculated based on the delivery events that happen from March 1, 23 to February 29th, 2024. So we're going to use that 1 year worth of deliveries and any claims relevant, you know, during that 200, or in this case, 2 trimester prior and then 90-day postpartum to delivery to calculate the case rate. So, you know, for the delivery happen, let's say on February 29, 2024, the 90-day postpartum can extend all the way to end of May, and that's okay. So we're gonna use this whole, I will say 2 years almost worth of event, but the key is delivery has to be during that 1 year of time period.
Next question, does anesthesiology receive a case rate as well?
So
Grace, we were just looking at this, right?
Yeah, we're just talking about it, and then it will, as long as it is billed by a correct billing specialty type, as well as within the attributed TIN. So if this, I can't say this word. If this individual is associated with a different provider network, a different TIN, then this claim will still get paid fee for service. But if it's the attributed provider network, the same TIN, and it's billed by the right professional type, specialty type, then it will be receiving a case rate.
So like anesthesiologists, for example, would not be the correct type and specialty.
Right.
Next question, what happens when the OB-GYN providers have the same TIN for the outpatient visits as well as office visits?
You mean inpatient, I wonder?
Yeah, possibly.
Maybe just whoever put that in, if you don't mind clarifying if you meant inpatient as well as office, or also feel free to jump in if you prefer to speak. We welcome that too. And if not, we can circle around to them. Because I think those are kind of under the same bucket for our purposes, I think, Charles and Grace, right?
Yes, for the most part. I think there's a bit of a distinction about professional services that are claimed from what is separately submitting their own facility claims. But I don't know if that's what's meant there.
Or maybe emergency department outpatient visits as well, potentially.
Yeah, right. Could be. Again, there the crux of it is a professional service by a provider within the TIN that meets the specialty practices that's submitting code within the zero pay code, and with either a trigger or subsequent to a trigger would be the sequencing. I don't know if that answers it in full though.
If not, please, whoever asked, please chime back in to make sure we got it.
And perhaps a note for the DSS and Mercer team, maybe when we release the FAQs, we'll kind of compile a list of all of the commonly asked case rate questions. We can include the specialty types that will be looked at for the case rate.
Great call out, Tiffany.
Does each provider have a case rate for each TIN?
Each accountable provider TIN will get 1 case rate.
What we are seeing is that there are facility only TINs or facility only claims in a tin where that provider group has a separate tin for professional fees. And that's not uncommon from what we understand. So the tins that are qualifying professional fees that have met the birthing threshold, they would have their own, each would have their own.
And then the system process the payment, we always also make sure those providers are the right provider type. So within the same tin, there might be other provider type, they will not get a case rate. Only certain providers within each accountable provider tin will get a case rate. Again, that is the requirement for the right specialty type. So as Tiffany said, we'll outline all those maternal care provider specialty type.
Yeah, and just to be sure, the providers won't get, the AVRS won't get their own case rate. They will participate within the tin that they are mapped to, rolled up into. And the tin will get the case rate.
Will you be reconciling fetal surgery cost with the target price? There's concern with how expensive they are and the financial impact to OB/GYN practices.
So as of right now, those costs are included. So they would contemplate a sustained level of necessity, for lack of a better term, or occurrence historically. And that deviation from that would be looked for in the reconciliation process when we look at claims and if we truncate to catch any outliers. If you had a particular event that's anomalous of what your historical experience showed, that was at a certain level of cost experience, we will do a look during the reconciliation process to see if those need to be excused from the claims experience because they created an anomalous event and result.
Yes, we will be capping those like very expensive episodes as Charles said, so that does help reduce some of that outlier risk that exists. And Kimberly or Kim, please keep my jump. So you asked that question, so please ask follow-up.
I know I'm asking a lot of questions. You're doing a great job, all of you. Thank you so much. I had asked the question about fetal surgery. The fetal surgery is what we're seeing is that they're often more than the cost of delivery. So the OB/GYNs are concerned that the majority of these patients are being welcomed into our ambulatory clinics in the hospitals. And so that's sort of a disparate expense for our ambulatory clinics. Thank you.
Yeah, understood. And they're the professional fees associated with that inpatient stay and surgery are contemplated because they're in the historical claims within your tin. Those facility costs will be looked at in the target price and the reconciliation. And then we'll have our actuaries will have a means of devising when it falls outside of the spectrum of historical costs.
Got it. And that is a growing practice in Hartford. So that would be the situation. Thank you for clarifying that.
Yeah, I'm sorry. And did you just say that's a growing practice as though we're seeing there's a natural trend line right now of an increase?
There is. Yeah. So there were probably none in the draft test period there.
Yep.
And as many as 25 last year and anticipated to be, maybe over 100 next year. So just really concerned for our ambulatory clinics, particularly at Hartford hospitals where I work.
Yeah, I think, and so our actuaries, Grace and her team, will be looking for things like that. We do all on all of the shared savings reconciliations. We do a category of service and kind of a claims level analysis of spikes and trend, or abnormalities in trend. That being said, if you could give us a heads up, it makes it a little easier for us. And then there is always an opportunity when we review results to spy something abnormal and bring back to us, understanding that the results are the product of the information that we have and the data that we know. So at any point in the development, we'll take it back now and contemplate it if there's a way to address it. But at any point, that type of information is super helpful to our actuarial team, both now at the point of the case rate development, the live case rate, and at the time of reconciliation. If it doesn't get incorporated at some point, and you don't see that there is a a recognition of it, that's we always welcome that to get it as right as possible.
And maybe just a note as well as those target prices are risk adjusted. So there's both a clinical and social risk adjustment that goes into that, which I'm not saying that alleviates the concerns you're raising, but just of note that those things are incorporated into that target price development.
Thank you.
One question from the chat. In the case of stillbirth, if the monthly payment stops with the birth, how does the provider get reimbursed for ongoing postpartum care?
Fee for service.
All right. If go live is September 2024, does this payment method only apply to newly patient pregnant after the go live date? What if we have a patient at 24 weeks at the time of go live? Are they paid fee for service at the time of delivery, or will they draw a case rate until their delivery?
I can take this one. So if the pregnancy is already at the 24 weeks time frame on September 1, 2024, again, we will be treating it as if it's an ongoing cases, meaning if there is a trigger event, a trigger claim billed from then on until the delivery case, then this whole case, all the case rate will kick in, if it's accountable provider, and just as if, so we won't really review claim that happened prior to the program go live. But obviously, if there's no trigger event from the 24 months to a delivery, then everything will just be billed fee for service per usual. So we won't review any claim prior to 9/1/24 to identify attribution. Hopefully that answers.
Yeah, that was helpful. Thank you, Grace. Next question, who falls under the eligible specialty types?
We can, I can pull that out. Just give me 1 second. I can answer that question. I know there's 6, let me see if I can find naming corresponding. I know the codes, but I just want to also provide the.
Thanks, Grace. I
Yeah.
don't think anybody wants to speak into them in codes.
Yeah, the codes, as someone who's learned them, it's hard to translate directly to provider language.
Absolutely, absolutely. Let me look for it real quick. Sorry.
Any other questions while Grace is pulling that? Quality methodology. Campbell posted one here, questions in regards to the quality methodology, which I know we haven't discussed today, but in general, obstetricians cannot prevent a baby from having low birth weight. Rather, they can suspect, diagnose, workup, and provide surveillance for a baby who is suspected to have fetal growth restriction. This would require extra-fetal testing, maternal testing, and serial ultrasounds. The OB should be awarded when they provide the correct diagnostic test and surveillance. However, for the quality methodology, the OB would be dinged if a baby is born and diagnosed with low birth weight. So this is just the quality measures and weights to them. So thanks for flagging this. Definitely heard a lot of useful feedback, I think, on this. This is kind of determined based on prior conversations that occurred. We pulled in Yale 4 team to help us with quality measure selection, and then also used our advisory committee to help with kind of finalizing these. I think just to acknowledge that one thing on the maternal adverse events, which we're not talking about, I know you mentioned the low birth weight, but just to say that that's one that we've actually adjusted down in terms of percentage. So this is our quality performance. There's a pay for performance. So how do you perform on these quality measures, and a pay for reporting, which as of now is specific performance, just for making sure we have the data. But we have responded a bit to that by decreasing the maternal adverse events from 18% down to 6%. I just want to acknowledge the concern on low birth weight is how much of that is impactable. I think we're not planning on making changes at this time, but we will be planning on reviewing this again moving forward, because this impacts provider's ability to generate shared savings depending on their quality scores. There's a quality threshold that they need to be meeting. So just want to say, hear the concern. We're open to further conversation moving forward on these measures and measure selection for post year one.
Yep, and I can go back to the question prior. The eligible specialty type includes 6. They are women's health nurse practitioner, family medicine, obstetrics and gynecology, certified nurse midwife, obstetric nurse practitioner, and family nurse practitioner. So those are the 6 types. If you would like, I can definitely type the answer in the chat in the Q&A as well.
Those types should be listed on the materials on the website, right? The specialty types.
Yeah, we can, if it
If
has.
not, let's put them there. I think that's let's not start another thread of specialty groupings. Good enough to list them here, but we don't need to produce them in the FAQs. They should be on the central website with the program documentation that is available to providers as well as our CMS counterparts. So the specific group that we're accountable to, that's where the official list should be. Right.
Those are all the questions we have so far, but we welcome additional questions if folks want to chime in or unmute.
Tiffany, did we have a recording on quality measures? I believe we did. Did that get published?
We do. DSS will be providing a more general program overview video in the coming weeks, and we can notify folks in this group when that's published. But that will include some more details around the quality specifically.
Kim, to your question, do you have one-on-one meeting offerings or contacts if we feel that our case rates are insufficient? One household offices a case rate of $45, or a large loss from current state. Yeah, I think that is a plan to offer additional. And Tiffany, do you want to comment on specifics?
I believe we're just open to setting that up by appointment for practices who are interested. So Brad, would you be the right contact for that, or would we want to go through the CHN team?
I'm happy to get those requests and then help figure out how we're going to follow up. So you can put my email in the chat.
What is the plan to train billers and coders about this new method of reporting?
Great question. We will have technical documents coming out in the future that hopefully will provide guidance to those in the administrative aspect of providing care. So there will be more details forthcoming. Well, if we don't have any more, I think we can end this. And I definitely welcome, and I think we welcome ongoing conversation. We know this is for some of you who've been following this for a while, some of this is new and hadn't heard about the details on this before. And we welcome the opportunity to engage and talk further about it. I think knowing that this represents a pretty significant change for providers in this space. We ultimately hope it will drive opportunity for change and hopefully improvement across across for our members, for patients, for providers in the long run. But we know this won't occur overnight, and that there's bumps along the way as anytime you launch something new. So I just want to acknowledge that, but also note that we see this as a hopefully significant improvement in the long run for how we're paying for prenatal care and obstetrics care and postpartum care. And we look forward to continue to work with you to refine this and make it better so that it does work for providers. It works for the state, and it really helps patients in the long run get more comprehensive holistic care by not focusing as much on making sure people have just as many fee-for-service visits as possible, which we know that the current system is really built around volume, and we hope we can move this towards more holistic value-based care, acknowledging again it will take time to see that change. So thank you all. Chicken, do we have my email just in case folks need it? We can post it in there.
Yeah, I just put that in one of the questions, but I'll also put that in the group chat so it's easy to access.
Just want to make sure. So thank you all. Look forward to talking more and connecting on this important topic. And please let us know if there's any further questions. And we appreciate the great clarifying questions that you all are asking. These things help us to make sure we can answer questions better moving forward and refine any areas that we need to. So thank you. Have a great one.
Thank you.